대학 정형외과 교육실 주임 교수님으로 계신 정현 선생님의 인사 말씀이 있으시겠습니다.
안녕하십니까. 날씨가 오늘 너무 좋습니다. 토요일이 이제 주 5일째 5일 근무로 토요일 쉬는 병원이 많은데 이렇게 아침 이런 시간에 예년에 비해서 더 많은 분이 이렇게 첫 세션부터 많이 참석해 주셔서 정말 기쁘고 감사드립니다. 오늘 해외 초청 연자 분들이 예년보다 한 분 더 많이 4분이 초청되셨고 또 국내 연자로도 여러분들 상당히 최근에 관심이 많으신 그 엔도베스컬러 트리트먼트에 대한 한문희 교수 강의도 굉장히 유익할 것으로 생각합니다. 오후 5시까지 좀 점심시간 1시간 제외하고 계속 심포지움이 있습니다. 좋은 시간이 되시길 바라고요. 해외 손님이 있어서 영어로 간단히 인사드리고 끝내겠습니다. Good morning. It is great pleasure and privilege for me to thank and to welcome all of you to this our annual symposium, Update Neurosurgery. This symposium was founded by Professor Dae-hee Han, our former chairman of the department, in 1991 in order to provide young neurosurgeons fundamental knowledge about an update advancement in neurosurgery. Since then, every year we invited expert scholars in every field of neurosurgery and shared their knowledge and experience. Today we will cover update in vascular, pediatric, and functional neurosurgery. And we invited 5 outstanding guest speakers from the US, Japan, and Korea. I should like to express my sincere gratitude for their kind acceptance of our invitation and their valuable participation. I wish all of you enjoy this symposium and have some new knowledge about update development in neurosurgical treatment. Thank you very much.
첫 번째 연재 시작하기 전에 안내 말씀드리겠습니다. 그 점심 식사는 여러분들 그 영찰 뒤편에 보면 식권이 있는데요. 그 식권을 가지고 지금 이 건물 11층에 가든뷰라는 식당이 있습니다. 거기 가셔서 식사를 하시면 되겠습니다. 그러면 그리고 지금 그 핸드폰 있으신 분들은 진동으로 좀 바꿔주십시오. 첫 번째 연재는 여러분들이 잘 아시는 한대희 교수님께서 좌장을 맡으시겠습니다.
여러분 반갑습니다. 저 슌로 엔더 교수를 잠깐 소개해드리겠습니다. 슌로 엔더 교수는 제가 알게 된 거는 제가 버테브로바질러 디섹션에 관심이 많아가지고 문헌을 쭉 찾다 보니까 이분이 그 뉴로서저리 저널에 그 아주 굉장히 중요한 그 오토피 케이스 5케이스를 갖다 리포트한 그런 걸 발표한 적이 있어가지고 내가 우리 레지던트나 학생들 가르치는데 좀 그 슬라이드가 필요하다고 그래가지고 우리 엔도 교수가 저한테 그걸 직접 보내주셨어요. 그래가지고 항상 감사하게 생각하고 있었고, 슌로 엔도 교수는 그 일본 그 혈관외과, 뇌혈관외과의 주류를 이루는 도호쿠 대학의 지로스즈키의 7번째가 8번째 제자입니다. 근데 이분의 그 전임 주임 교수는 다카쿠라고 도야마 그러면 여러분들 일본 혼슈에 일본식으로 말하면 재팬시, 우리식으로 하면 동해 연안에 있는 인구 30만의 소도시입니다. 근데 이분이 그 도야마 메디컬 앤드 파르마시우티컬 유니버시티의 디파트먼트 오브 뉴로서저리의 체어맨입니다. 그래서 체어된 게 아마 since when chairman? 5 years?
1999.
1999년도에 그 다카쿠 교수의 체어를 갖다 이어받으셔갖고 이분 보시다시피 아주 건 모양하고 똑같이 아주 수수하고 촌스러우면서도 아주 뚝심 있고 그런 분입니다. 그래서 오늘 이분이 강의할 게 우리도 굉장히 관심이 많은 그 카로티드 스테노시스에 대한 얘기하고 또 우리 그 신경외과 질환 중에서 굉장히 그 수수께끼 같은 질환인 듀라이브에 대한 말씀을 10시 50분까지 하겠는데 첫 번째 강의를 마치고 또 우리 디스커션 피드백을 많이 하는 게 좋을 것 같아서 디스커션 좀 하고 또 두 번째 연재 이렇게 하겠습니다. Professor Endo, please.
Good morning, everybody. Thank you very much, Professor Han, and thank you very much, Jan. I'm very honored to be here, and thank you very much for your invitation. Yeah, I came from Toyama, as Professor Han introduced me. Our university is a medical and pharmaceutical university, unique university. We have a Institute for Experimental and Clinical Study of Oriental Medicine. But I'm surgeon. So today, I would like to speak about the first paper, management of patients with high-grade carotid artery stenosis. Especially, I would like to introduce our Japan Carotid Atherosclerotic Study, JCAS. Initially, I must say, I am not good to speak, especially Hangul, English also, and Japanese also. So I hope to understand what I want to say. So start my paper. This is my policy for surgery. Evidence and experience-based surgery is my policy. And the anatomy and pathology of the region is the most important evidence for surgery. Carotid artery surgery is so popular and important for a vascular surgeon in the world. So today's topics. I want to speak initially anatomical and pathological characteristic of the carotid artery atheroma plaque. I would like to introduce our basic data of carotid artery wall structure and plaque extension and calcification. And second, I show preliminary result of the ongoing prospective and multi-center study of carotid artery disease in Japan, JCAS. Initially, I want to confirm the relationship of angiography and anatomical view of carotid bifurcation. This is simple one. This is a branch of ECA. So young surgeon, please confirm this point. This is carotid bifurcation on angiography. On surgical view, this is bifurcation. There is a difference of the location of carotid bifurcation. To know this is important for approach to carotid bifurcation in surgery and endovascular treatment. And also, we investigate 98 branches of carotid bifurcation, especially about ascending pharyngeal artery. So in the series of 98 branches, 4 branches originated from carotid bifurcation or ICA. Please remember this at the preparation of and occlusion of carotid artery. So this is a trauma plaque at the carotid bifurcation. As you know, plaque is located at the bifurcation from the origin of ECA to the from the bifurcation to the origin of the ICA, plaque is located. It's common sense. Especially this limit area, this part of from plaque to the distal ICA is clear. So, for example, this is bifurcation, this is atrial plaque. Distal site ICA, sometimes intima is thick, but in our series, yes, this part, there are no atheromatous change. If there is a thick intima, distal ICA intima is just only simple thickness. So not atheromatous change. This is important to do, remove the atrial plaque from the arterial wall. So this is another information. Do you know, I think you know, artery, there is a two characteristic artery, elastic artery and muscular artery. CCA, carotid artery, is elastic artery, and ICA, muscular artery. What is the difference of this artery? Johnson decided in his report, recent report, muscular artery had just only they counted elastic fibers into muscular layer, and so they decided muscular artery had a elastic fiber less than 5 elastic fibers, and elastic artery have more than 11 elastic fibers. They decided. So depend on this, we observe the carotid artery, common carotid and bifurcation with atrial plaque and distal ICA, and the relationship of the atrial plaque, distance of the atrial plaque and the thickness, and elastic artery or muscular artery. So this is the result. Okay, so sorry, this is Japanese. We measured border of elastic artery and muscular artery. We call the from the elastic artery to transitional zone and muscular artery. Okay, so border of between the elastic artery and transitional artery at a point from the bifurcation we measured mean 5.25 millimeter here. Okay, and transitional and to muscular artery mean 18.57 millimeter. So we measure the line, this line, average mean line here, proximal site from elastic to transitional, and from transitional to muscular artery. So this is a part, it's A, B, C, D, means classification of atrial plaque thickness. D is thicker. A is without plaque. This is a distance of a distal part of a plaque. So this data means atrial plaque are included between the transitional zone, not muscular layer. Of course, there are rare cases, extra cases. About 19% in our study, in our cases, included in this criteria. So, atrial plaque, we concluded, and we know, we understand, atrial plaque of the carotid artery is a localized region at the carotid bifurcation and the origin of ICA, where is a transitional zone from elastic artery, CCA, to muscular artery, distal ICA. This information is sometimes very important for, especially in a case such as pseudo-occlusion cases. Distal site is unclear. If I know, basically, distal sites within about 18 or something, at least more about 20 millimeter, distal site we can decide easily. For example, this is storing, and we can see the distal site. Probably, atronal plaque is located here, just only located here. Distal part is no atroma. So if I set the stent, this is a distal site. We can do probably easily and safely do surgery and stenting based on this thinking. About calcification, there are some calcified region at the carotid bifurcation. Sorry, poor picture. I think one point I would like to say, atronal plaque, thick calcification associated with atronal plaque is located at the most outer side of atronal plaque, so no inside of the atronal plaque. So we must take care to remove the atronal plaque with thick calcification, not to damage of the muscular layer or adventitia. Anyway, high-grade stenosis of a carotid artery is advanced atronal plaque with various pathological changes. However, this region, localized and benign and organic region, yes, this is a good target for surgical procedures. I believe so. I change the next topics. As you know, carotid endarterectomy is so popular for vascular surgeon. There are so many data, NASET, ECSD, ACES, RCT study, so many evidence for efficacy of carotid endarterectomy to prevent the future stroke. However, in the Cochrane review, meta-analysis data, significant evidence is just proved only prophylactic CA in symptomatic high-grade stenosis, more than 70% stenosis. It's just only one evidence proved by meta-analysis. So very significant no evidence is now still there. There are some in subject. CA in symptomatic 50 to 60% stenosis or asymptomatic high-grade stenosis or surgical techniques is now discussing is continued, shunt, patch or something, and or emergency or urgent treatment. And especially recently, CA or stent is a hot target for treatment. Especially stent is not available with complete evidence for clinical use. And these data come from European and American countries, and we have no evidence in Japan. But in Japanese patient, is a characteristic of carotid artery disease so different from the European people. Case is rare, and some characteristic difference. So we started our Japanese prospective and multi-center study. I'm sorry, this study is non-randomized style, but the new study we started for clinical data analysis and guideline proposal of high-grade carotid stenosis of carotid artery. So this study, including cases CA, stent, and medical, and 78 centers of neurosurgery, neurology, and so on included, and started at 0.2, and this year, almost I will finish. This slide shows the design and organization of JCAS. this study is supported by the research grant for cardiovascular disease from the Ministry of Health, Laboratory and Welfare. And the Institutional Review Board approval, and patients' accessibility and willingness and valid informed consent were confirmed. And all patients and participants with more than 50% carotid artery stenosis, including high-risk patients, were enrolled. And medical treatment, CA or CAS stent, were selected according to the decision in each institute. And until the July last year, registration of 10,014 patients were registered. This slide shows the patient and symptoms. Of 1,040 patients, 882 patients male, and female just only 132, and the average is here. And half of them symptomatic, and half of them, another one, asymptomatic. This measures about the patient of the stroke, major, minor, or TIA, or retinal stroke, they showed. This is a medical risks. This bar shows total and male and female. Hypertension is the most important medical complication. And diabetes mellitus rate of DM is not so high. This is a complicated coronary disease, less than 30%, and so on. Hypertension is the most important risk factor for carotid artery disease, I think. This is plaque features. 70% of plaque had more than 70% stenosis. And ulceration was 35%, and calcification 28%. This shows a plaque feature. Location, this cervical vertebra and the distal side of the atheroma plaque. Yes, in Japanese, maybe also in Korean people. Carotid bifurcation is higher than European people. And relatively, we have so many cases of high region carotid artery disease. So surgery is a little difficult. So this slide shows that. And this is echo findings, high echoic and low echoic, isoechoic, and mixed. And most of 50% of these patients had a contralateral ICA. Contralateral ICA stenosis or occlusion. So this is a category of treatment. 44% CA, 31% CAS, and 5% medical treatment was selected for patients with more than 50% stenosis of carotid artery, and mainly 70% had more than 70% carotid artery stenosis. And symptomatic 511 cases, about more than 80% was CA or CAS was selected. In asymptomatic cases, almost 1/3 these CA, CAS, and medical. In symptomatic cases, more than 70% stenosis, almost 90% of patients was treated by surgery, and also more high severe critical stenosis cases, also surgical treatment was selected. I think this data shows we select patient depend on the data of NASET or ECSD. Symptomatic, we believe the data of NASET, European people's data. On the other hand, about asymptomatic cases, more than 80% stenosis cases, 80% patients were treated by surgery. But in the case with less than 80% stenosis. Medical treatment is more. So American Association of Stroke recommended, ACAS data showed, presented effectiveness of asymptomatic patient carotid artery is effective if patient had more than 60% stenosis. But later, American Heart Association recommended the surgery for asymptomatic cases will be good for the patient with more than 80% stenosis. They changed the recommendation. So Japanese Institute believes the American second opinion, and we do now 80% stenosis, more than 80% stenosis asymptomatic cases is now doing under surgery. But personally, I think for asymptomatic cases, surgical treatment is good or not enough or not necessary, I don't know. I think, asymptomatic case is an indication for medical treatment, I think so. So anyway, this is result. I show the complication with 1 month after treatment in our series. Patient number in CA 444, and total complication 47, and neurologic and non-neurologic. But persistent deficit, mobility 11, 2.5%, and mortality only 1 patient. This case is died due to hyperperfusion intracerebral hematoma after heart attack after surgery. This is the CAS data. Also, mortality morbidity is 11, 33.5%. There is no significant difference. This is a detail of the cause of complication in CA, and this is a permanent deficit. So main cause of complication is ischemic complication. Most causes is embolic complication. So 7 here. And hyperperfusion is so important complication also. Intracerebral hematoma, 3, and 2 of them, in patient of 2 of them, persisted permanent stroke. Other neurological deficit 1. So cranial nerve palsy 2, okay? These are mortality and morbidity. On the other hand, this is a complication of CAS. Totally, most big problem is ischemic. Of all cases, embolic stroke. And long-term hypotension. This is carotid sinus reflex. This all, in many cases, we experience this sinus reflex, and we must take care hypertension and bradycardia in stent. So finally, not so big problem. So intracerebral hemorrhage due to hyperperfusion is also serious complication. And this is characteristic, this is unique for, this characteristic problem of angiography stent. Angiographical complication, contralateral ischemia, and cerebral hemorrhage. There are such a complication we don't experience in CA. So anyway, judging from these, our data, we must take care more distal embolism, focal complication, CA, carotid sinus reflex in CAS as a technique. Of course, about restenosis, we have no our data. We continue and follow up these patients. And also, we must take care more about clinical feature, hyperperfusion syndrome, general complication to improve our data. Especially hyperperfusion it's important and serious complication in a surgical procedure. Stent also, CA also. And we now, in our series, we have many cases of data of many cases about SPECT study. So we analyze the data of SPECT, and we would like to make a new guideline for treatment to prevent hyperperfusion in the future. This is another topic. Recently, in the Lancet, last year, in the Lancet study, endarterin for symptomatic catheter studies in clinical subgroups. In the data, benefit from surgery was greater in men aged 70 years or older, and surgery within 2 weeks after last ischemic event. This is a new information from NACET and ECSD. We now doing emergency or urgent procedures for critical ICS stenosis with repeated TIA or mild progressing stroke cases. We do now aggressively, such cases near occlusion cases. So this is a result. 25 patients with pseudo occlusion or TIA is progressing stroke. Successful procedure. We got successful procedures in every cases. No thrombosis in the distal ICA, and complete revascularization was taken. And we have a good outcome. No post-operative aggravation, no hyperperfusion syndrome. And this is important. Disappearance of neurological symptoms in 21 of 20 stroke patients was seen. I believe in critical stenosis cases, if patient had a TIAs or mild stroke in evolution, we would select the surgery. Oh, of course, including stent. I would like to do so. So, final message from me. In these 30 cases, which we did emergency CA or stent, they had all cases had more than 90% stenosis or pseudo occlusion. I would like to say about symptom of these cases. They had unstable neurological deficit, 5 crescent TIAs, 25 stroke in evolution. Especially, these 20 patients had 21 had TIAs initially and followed by stroke. Just only 4 primary stroke are seen. So we must take care about the TIAs, especially repeated TIAs more, and must check the patient and find the patient and treat smoothly. This is early result of JCAS. Good surgical result in CA CAS. CAS cases including, although national insurance is not available for clinical use of stent. About indication, symptomatic cases, NACET indication, yes. And timing of procedures is more important factor. I would like to find the answer. In asymptomatic cases, ACAS indication is not so clear now. Thank you for your attention.
Thank you. We have enough time to discuss. So there are many issues concerning the carotid artery stenosis. So if you have a question, 질문 있으면 좀 하시죠. 질문이 없으십니까? 시간이 20분쯤 있는데요. 디스커션 할 시간이. 우리 한 분이 계세요.
Thank you for your nice lecture. And I'm Moon Hee Han, a neuroradiologist working for Seoul National University Hospital. And actually, last night we got lost my my patient because of massive intracerebral hemorrhage just after carotid stenting. And you have already briefly mentioned about your own guideline to prevent such a hyperperfusion syndrome. Can you comment briefly on that?
I cannot say well, but we now discussing about guideline to prevention of hyperperfusion. So, for example, one doctor of our members are thinking propofol anesthesia, they used in anesthesia control after CA or stent in patient. They measured SPECT study and SPECT or TCD. Yes, and yes. Sorry, I'm confusing. Important point is which is we don't know the critical level of the patient who will go to hyperperfusion or non-hyperperfusion. In our consensus, we would like to decide the risk level is a elevation of a CVF by SPECT or TCD changes more than 50%, from 100% before surgery, after recanalization, more than 150, over the 150%. In such cases, we take care of hyperperfusion, and some doctor use anesthetic control. And we have another idea, but we cannot say clearly now, but medicational control, we are now researching now. It is okay?
또 질문 있으시면 하시죠. 그러면 제가 질문을 I will ask you several questions. The first one is that the in which case you will go to carotid endarterectomy, in which case you will do stent. According to the Fred Meyer, Mayo Clinic, I'll discuss with him that if his or her life expectancy is more than 10 years, he will go to carotid endarterectomy, and if the patient is very sick and very old, he'll go to stent. So what's your policy and trend in Japan? Stent or CEA?
Maybe patient will select in the future. This is my answer. Okay?
But patient doesn't know anything about carotid stenosis. So
Yes. Personally, I think in the near future, stent most in first choice for treatment. But the risk or degree of restenosis is not so clear. Of course, stent surgeons say, yeah, if we have a restenosis, we can do again restenting. It's no problem, they will say. But I think, anyway, carotid artery direct surgery is relatively easy and radical treatment. So I like to do surgery, but result
patient
over
no.
Patient maybe
Doesn't like.
to the extent. Yeah. Anyway, result is CA and stent is almost same. In Japan, complication rate is low, less than about 3%. But finally, we must select the case depend on the calcified region or degree or feature of the carotid artery disease. So anyway, this discussion, stent or CA, will continue from now.
Another question is that what's your most important procedure to prevent unexpected ischemic complications after carotid endarterectomy or carotid stent? What are you doing? You have many ischemic complications after surgery. What is the necessary procedure to prevent post-operative ischemic complications?
Your question is, every question is difficult. I think we do our best now about the ischemic complication, to prevent ischemic complication. I don't know. I think we do now. Most procedure we can do, which we can do. So about 1.5% is a complication due to the ischemic complication, due to a technical complication, especially embolic complication. I'm sorry, I think we cannot make a zero of ischemic complication by this procedure. So, but our target, I think our target is to prevent hyperperfusion. It's more important clinically. Okay?
I think the hemodynamic evaluation preoperatively is the most important thing. And
Of course.
that, there are two kinds of ischemic complication. Maybe one is low flow.
Complication
Yeah.
due to low perfusion,
Low flow. Yeah.
low flow.
Because of poor collateral circulation. Yeah.
It's
The second one is the embolic complication.
No.
So, yeah. So, do you use the shunting?
Yes, in their case we use shunt.
In what case do you use shunt?
We monitored SEP during surgery, and big change within 5 minutes after occlusion. We use shunt, but in other shunt case we don't use shunt. I want to emphasize complication, ischemic complication. Most ischemic complication occurred due to embolism, not hyperperfusion.
My last question is, do you use a patch or not?
I don't use patch,
Me too.
but good answer, patches or not, I cannot answer.
Okay. Any question? 그러면 we'll move to next topic. Okay.
No?
Yeah?
Professor Kim.
Cookie Kim, welcome. 소리 안 나오는데?
Nice presentation. I'd like to know, as Dr. Han and you said, the patient will choose because patient want non-invasive surgery. There is a tendency to increase like GDC and other gamma knife is increasing in also in Korea, and I think in Japan also. So the patient want to be not general anesthetic operated, so increase in local anesthetic stent will be increased in future. I'd like to know are there any comparison the long-term follow-up after stent and carotid endarterectomy about restenosis and the long-term clinical outcome result? Are there any result report? Do you know?
You mean in general reports?
After surgery, carotid endarterectomy and long-term follow-up.
We have.
Yeah.
You know.
And about stent.
stent.
Yeah.
Yeah, also, recently, some paper is presented, published, about the restenosis of stenting. Not
What about the
recurrence,
result?
not so high,
That's high.
almost
Same, similar result?
similar of CA.
Thank you.
Okay, so Professor Endo, you had a hard time, huh? So we'll move to more hard time to next topic.
Yes.
Okay. Next topic is the clinical experience and investigations of the dural AVF. Please.
Just a moment. About next topics. Next topics is dural arteriovenous fistula. Especially, I want to speak combined endovascular and surgical treatment of high-risk dural arteriovenous fistula presenting aggressive venous hypertension. Histopathologically, dural AVF is a shunt located between the dural arteries and dural sinus. And size of fistula is about 0.2 millimeter, such as this is a sign AVF portion, and this is a characteristic feature of pathological feature. This is pathological report is presented by our colleague Nishijima and Etor in 1992. And recently, endovascular procedure is so popular. TAE using coil particle glue, and we can get flow reduction and permanent effect. So mainly, sinus packing is so popular. Transvenous and surgical transvenous or direct approach and radical. So by sinus packing, we can get the radical effect by endovascular treatment. So recent such an improvement of endovascular procedure has contributed greater to the better treatment result of dural AVF fistula. However, some regions remain still difficult to treat only with endovascular intervention. So to emphasize the efficacy of combined endovascular and surgical treatment of high-risk dural AVF, particularly with vigorous retrograde left meningeal venous drainage due to severe restriction of the venous outflow. This is target today's topic. This is our experience, recent experience, 45 dural AVFs in our clinic. Cavernous sinus region is, 46%, and the transverse sigmoid sinus 33%, and others 21%, and including superior sagittal sinus, marginal sinus, anterocranial base, cranial cervical junction, tentorium, and convexity and spinal. So in these cases, 80% patients were treated conservatively, and 3% by radiation, and 12% surgery, and 52% were treated by endovascular, and other 18 cases, 50% were treated by endovascular and surgery. So of these 80 patients, 3 cases were treated by operation after embolization, and 15 cases were treated by direct sinus packing and surgical transplant embolization. About these methods, we reported by journal. So these cases, these patient with need endovascular and surgical cases, this is characteristic feature of these cases. Restriction of venous access route, sometimes isolated sinus. So aggressive symptom of intracranial hypertension and or hemorrhages due to retrograde left meningeal venous drainage. So, and need emergency and radical treatment. These characteristic feature of these patients. I would like show the cases. This is This 48 years old man presented with intracerebral hematoma due to cavernous sinus dural AVF fistula draining only into the vein of the Sylvian fissure. At first, we went into the cavernous sinus with a microcatheter, but the sinus had a tight septum and did not allow us to enter the shunt cavity. So there were no other percutaneous venous routes to the involved cavernous sinus. So we decided to do surgical transverse embolization. One of the draining cortical vein was exposed by open surgery, and microcatheter was navigated into the involved cavernous sinus via this superficial medial cerebral vein. The sinus was successfully packed under the intraoperative angiography. This is a picture of after treatment. This slide shows our classification of transverse sigmoid sinus dural AVF, depend on the location of lesion and flow. So red part is blood flow. Okay, so A type is isolated sinus and venous return to the left meningeal part is target of this study. So combined treatment of surgery and vascular treatment. This lady who presented with status epilepticus, angiographic revealed the dural AVF draining into the isolated transverse sigmoid sinus with a vigorous retrograde left meningeal venous drainage. We can see a marked cerebral venous stasis. We performed a small craniotomy and exposed the transverse sinus under general anesthesia, and the microcatheter entered from here and into the involved sinus, and the region was successfully obliterated by direct sinus packing under intraoperative DSA. Oh, sorry. And this is a more complicated case. This patient presented with multiple intracranial hemorrhage. Both the transverse sinus and the conference were involved, and the bilateral cerebral venous return was markedly impaired. So involved sinus was successfully occluded by the same technique as the direct sinus packing, and post-operative course was excellent. This is a man who presented with progressing dementia and weakness of the extremities. He had a dural AVF draining into the superior sagittal sinus, and sinus was occluded, posterior part of sinus was occluded. And this outflow restricted caused by the retrograde drainage and the marked venous stasis in the hemisphere brain. So the sinus was occluded. A sinus occlusion did not allow us to get the root into the shunt cavity percutaneously. We decided to do the direct sinus packing. So we expose the involved superior-sagittal sinus by midline skin incision and tuber hole craniotomy, and the sinus was cannulated and obliterated with microcatheter. This angiography immediately after direct sinus packing, the AV fistula disappeared completely, but we see the marked venous stasis still in the brain. So, oh, sorry. But, and we followed this patient 3 months after treatment. Good venous collateral circulation developed and stasis disappeared. This is a treatment result of the 50 patients. There were no procedure-related complications, and angiographically, all region was completely obliterated after treatment, and clinical outcome was acceptable. Good recovery, 13 patients, moderate disability 2, and severe disability. I'm sorry, only one. I lost one patient due to heart disease. We presented about some cases we did. Initially, we tried endovascular surgery, and after that, we must do combined surgical treatment cases. Of course, in another regions, we have some another surgery cases, anterior cranial base and cranial cervical junction and tentorium. These cases, for example, this is a anterior cranial base AVF. This case, patient, 58 patient, showed a big hematoma, and we treated this case at direct surgery and clipped draining route intracranial site. Also, craniocervical junction is a good indication for surgical clipping of the draining vein. I think, not indication for endovascular treatment. Also, tentorium cases, we did, in this case, initially, transarterial embolization and surgical treatment. These cases are good target for surgical cases. This is summary. High-risk dural AVF sometimes need combined endovascular and surgical treatment. Characteristic feature of these regions were aggressive behavior resulting from retrograde left meningeal venous drainage due to the restriction of the venous outflow, and combined endovascular and surgical procedures, sometimes on emergency basis, may be a safe and very effective treatment for the patient with these high-risk dural AVFs. Thank you.
Thank you. 질문 있으면 하시죠. We have enough time, maybe 40 minutes for discussion, so too many times. But 한문희 교수 안 계신가요? 한문희 선생님께서 좀 코멘트를 한 10분만 좀 강을 못 들었어요? 그럼 한번 강의 다시 들을까요? In the statistics, in Western countries, the transverse sigmoid sinus fistula is the most frequent, but in Japan or in Korea, carotid cavernous fistula is the most frequent one. So, do you know why? Carotid cavernous fistula is the most frequent one in Japan or Korea, but in the Western countries, transverse sigmoid fistula is the most frequent one. So,
Is it true?
I think so.
think so?
Warodaki or
I think think there are so many patients with transverse sigmoid sinus dural AVF, especially benign cases, who complain just only tinnitus. If we do more aggressively examination, especially, yeah, in some cases, if we do MR angiography commonly, but we cannot find dural AVF, especially benign, small AVF, transverse sigmoid sinus AVF, we cannot find. So I think there are more patients in Japan or Korea also of the two patients with dural sigmoid sinus.
Do you believe that the incidence is same as the Western country?
Yeah, I think
But
so.
you know, the Dr. Warodaki, he
Turkey.
presented some paper as well as the Professor Munihan also. How about 한명 선생 얘기 좀 해주시죠. 그 카르티드 캐버너스 피스툴라가 우리 동양에서는 더 많은 것 같은데.
In our series, the instance of the dural AV fistula in cavernous sinus is much higher than posterior dural sinus lesions in this country. And the aggressive lesion causing venous hypertension with cortical venous reflux is much more frequent in posterior dural sinus lesion in our experience.
Just a moment. This is a this is our data.
Yeah. But your data has more
Higher.
transverse sigmoid sinus incidence comparing to other series.
I think so. Yeah, I agree you about my data, but in my impression, we have more patient with transverse sigmoid sinus dural AVF.
또 질문 없으십니까? 김정은, 오케이. So 질문 없으면은요. Okay. Thank you very much.
Yes, you okay? We have time. I would introduce my,
You have another topic?
no,
No? Okay.
just only a picture. This is East Sea, Japan Sea, and we have mountains. Please welcome next time, Koyama. Thank you very much.
시간이 좀 많이 남았습니다. 그래서 커피 브레이크를 좀 땡겨서 10시 50분까지로 하고 10시 50분부터 두 번째 토픽을 시작하는 걸로 하겠습니다. 그 사이 저 전시 공간이 마련돼 있는데 많이 좀 둘러봐 주시기 바랍니다.